renal infection. Okay, so the recurrent UTI is more common in female. Okay, okay, and mainly affecting the 30 to 40% in the sexually active group. Okay, okay. So this is the mainly the inflammatory response of the urothelium. Okay, okay, that is the host response. Okay, to invading bacteria. So what is pyuria, what is asymptomatic bacteriuria and UTI? So first we understand the pyuria. The leukocyte in the urine is known as pyuria. Okay, okay, and when the bacteria is present in the urine without any symptom, it is known as asymptomatic colonization or asymptomatic bacteriuria. That is ABU. When there is a symptom, it is called as UTI, urinary tract infection. Okay, okay. So UTI classify as a uncomplicated, okay, and complicated. So uncomplicated, it is an immunocompetent. The host is immunocompetent, okay, with anatomic normal and functional urinary tract. In that case, it is known as uncomplicated. Three things: immunocompetent, anatomically normal, and functional urinary tract. Okay, okay. So if it involves the kidney, it is known as pyelonephritis. If it is involved the urinary bladder, it is known as cystitis or urethritis or prostatitis, depend on urethra and prostate respectively. Okay, okay. So now come to the chronic pyelonephritis. So it is only morphological description of previous infection related scar. Okay, okay. That is seen on radiological imaging. Okay. So chronic pyelonephritis is a morphological description. Okay, it is not a pathological, it is a morphological. Okay, now come to the acute pyelonephritis. So acute pyelonephritis because of ascending infection from the lower tract. Okay, mainly because of gram negative bacteria. Okay, gram negative bacteria. Okay. So it may go through hematogenous in case of diabetes or immunocompromised host, or people taking the drug, injected drugs, or with bacterial endocarditis. Okay, and it is more common in female. Okay, again it is more common in female, especially during childhood, puberty or intercourse, or during pregnancy. Okay, so more common in female. Okay, and the symptom of acute pyelonephritis is usually present with fever, chills, flank pain, nausea, vomiting. Okay, okay. So pyuria is almost always present. Okay, pyelonephritis में pyuria there will be always present. Okay, and if it is absent, it may indicate obstructed urinary tract. Okay, obstructed urinary tract. Okay, and urine and blood culture should be done in acute pyelonephritis, and most common organism is E. coli. Okay, E. coli. Okay, and the first imaging modality is renal ultrasound. Okay, and CCT is, in CCT you will see the decreased patchy ossification of affected parenchyma. Okay, decrease. Okay, okay. Now come to the pyelonephritis complicating pregnancy. Okay, so because of progesterone relaxing effect, urethral smooth muscle relaxation and dilatation resulting in ascending upper tract infection. Okay, so this may lead to fetal growth retardation and preterm delivery. Okay, so that's why all pregnant women must be screened in the first trimester for asymptomatic bacteriuria. This is important. Okay, so lower tract infection generally occur in first trimester, and second and third trimester because of ascending infection pyelonephritis may occur. So starting from the lower tract, the second and third trimester it may go to kidney. Okay, so pyelonephritis is more common in pregnant female. Okay, with underlying urological abnormality or diabetes. Okay, and the antibiotic treatment during pregnancy is phosphomycin, penicillin or cephalosporin. Important. Phosphomycin, penicillin and cephalosporin. Now come to the renal and perirenal abscess. Okay, so if there is a obstruction, it because of vesicoureteric reflex and all, it may lead to E. coli infection or other gram-negative bacilli infection. Okay, so renal abscess may extend and perforate the renal capsule. In that case, it is known as perirenal abscess. Okay, perirenal abscess, and multiple renal abscess may conglomerate into solitary suppurative lesion known as renal carbuncle, and renal carbuncle is most commonly because of staph aureus. Very important, it's not because of E. coli. Carbuncle is staph aureus. Okay, and is spread through hematogenous route. Okay, okay. So clinical presentation may be persistent fever, back pain, abdominal pain, and costovertebral tenderness. Okay, and urine examination may be normal if the abscess does not communicate with collecting system. Okay, so and CCT is investigation of choice. Okay, and will give the antibiotic without drainage. Okay, in case of stable patient up to 5 centimeter. Okay, selected patient 3 or stable patient up to 5. You remember better 5 centimeter. So antibiotic treatment in renal abscess up to 5 centimeter can be managed through antibiotic. Okay, okay. If it is more percutaneous aspiration needed when it is more than 5 centimeter. If it is not managed through percutaneous aspiration, we can go for open surgical drainage. Okay, okay. And we can also do culture directed antibiotic. Okay, for at least 2 weeks or even longer. Okay. Now come to emphysematous pyelonephritis. Important. It is an acute onset, rapidly progressive, and possibly lethal form of pyelonephritis. Okay, so it is emergency. So parenchymal necrosis and gas formation occur because of E. coli, Klebsiella, Pseudomonas, and Proteus. Okay, so 4 organisms: E. coli, Klebsiella, Proteus, Pseudomonas, and Proteus. So you can remember this E. emphysematous E. coli, P for Pseudomonas, and Proteus mirabilis. Okay, okay, and this is mostly occur in diabetes. Okay, and obstruction secondary to calculi or papillary necrosis. Okay, in this CCT abdomen is diagnostic, and so gas in parenchyma important. Okay, and we give broad spectrum antibiotic and percutaneous drainage of abscess, or may lead to emergency nephrectomy is also rarely required. Okay, okay. Now come to xanthogranulomatous pyelonephritis. So it is a granulomatous. Okay, short form is XGP. So severe renal infection in an obstructed kidney. Okay, so obstructed word is important. Okay, okay, usually associated with calculi. Okay, loss of function and parenchymal destruction. Okay, so in this you will get the lipid laden foamy macrophage. This is asked in 1000 times. Lipid laden foamy macrophage associated with XGP. Okay, and the clinical feature will be flank pain, fever, chills, persistent bacteriuria, and flank mass. Okay, so mostly this is, if there is a stone history, it is usually unilateral. Okay, and CCT is diagnostic. It will show non-functioning enlarged hydronephrotic kidney with shrunken pelvis and acalculus. So hydronephrotic kidney, shrunken pelvis with calculus. Okay, and you will get the Beer-Posh sign. Okay, Beer-Posh sign, and patient may need nephrectomy as a definitive treatment. Okay, so in this I will say at least you should remember 2 points: lipid laden foamy macrophage and Beer-Posh sign. Okay, okay. And in this you can see you can go for antibiotic or nephrectomy. There is no role of drainage in xanthogranulomatous pyelonephritis. Okay, okay. So this is picture of Beer-Posh sign. Okay, okay. Now we'll see few more points from Sebastian. Let's see what Sebastian says. So substance is pyelonephritis. So pyelonephritis treatment is given outpatient basis with the oral antibiotic for 1 or 2 weeks. Okay, okay, and you should do urine culture. Okay, okay. Now come to emphysematous pyelonephritis. So advanced form of pyelonephritis, and it is urological emergency, mainly seen in diabetic patient. Okay, okay, and there is a gas forming organism, that is E. coli. We have already seen, and other organism are E. coli, Proteus, and Klebsiella. Okay, and there is a urgent percutaneous drainage. Okay, and this is the CCT picture of emphysematous pyelonephritis. Okay, okay, few more points, and you can do rapid nephrectomy. Okay, this percutaneous drainage infection or rapid nephrectomy. Okay, okay, and you have to give broad spectrum antibiotic. Okay, now come to xanthogranulomatous pyelonephritis. So it is a chronic infection. Okay, and because of renal obstruction, recurrent infection, or renal calculus. There are three forms: focal, segmental, and diffuse. Okay, and there is a foamy lipid laden macrophage, already told, and there is a extensive inflammation and fibrosis and loss of renal function, and there is a collecting system dilatation. So for focal and segmental disease you can give antibiotic. For diffuse disease you have to do nephrectomy. Okay, and in this there is a risk of iatrogenic adjacent organ injury because of fibrosis and all. Okay, okay, this much you should know about infection in kidney. Thank you.